Prevent this deadly disease. It's a great pleasure to introduce Professor Kaushik Rai to talk to us on current approach on reducing the cardiovascular risk factors in coronary artery disease. Professor Kaushik Rai is a president, European Cirrhosis Society. He has a long CV. I'll make it understand how important his research papers. Is a public health director of Imperial Center for Cardiovascular Disease Prevention and deputy director of the Imperial Clinical Trial Unit, Imperial College London, and consultant cardiologist. He is currently the president of the European Atherosclerosis Society, chair of the World Heart Federation Cholesterol Roadmap 2021-22, chair for Global Council for Heart Health, National Lead for Cardiovascular Disease NHR Academic Research Collaboration. Clinical Director for Research HDR UK Digital Innovation Hub Discover. He has more than 100,000 citations and since 2018 has been recognized by Clarivate Analytics as among the top 0.1% of authors in global medicine. I greatly welcome Dr. Kaushik Rai to talk to us on prevention of cardiovascular disease. It's over to Kaushik Rai, please.
So thank you very much for the kind invitation to be speaking at this important meeting in Sri Lanka. It's my pleasure to give this talk, the title of which is Reducing Cardiovascular Risk, Current Approaches. My name's Kaushik Rai. I'm a professor of public health in London at Imperial College and president of the European Atherosclerosis Society. These are a list of my disclosures, and I'm going to start by using this as an example. We need to move away from looking at individual risk factors in isolation, and instead we need to think about global risk. That is really exemplified in this particular slide, where we compare the difference in terms of absolute event rates over 5 years in individuals with blood pressures ranging from 110 to 180. And you can see that higher blood pressures, of course, are associated with a higher event rate. However, the absolute risk goes up, not just with blood pressure, but related to how many additional variables you have. So if total cholesterol is high, if you smoke, your HDL is low, male gender, diabetes, older age, you have the same gradation in risk in relative terms. So this person here, with all of these additional risk factors and comorbidities, even though they have a blood pressure of 110, has an absolute risk much higher than somebody here with a blood pressure of 180. And that's why you have to think about global risk. So we start, obviously, always thinking about diet, exercise, and smoking cessation, if you like, primordial prevention. But in those at highest risk, these may not be enough. And our healthcare systems, to some extent, are designed to treat disease rather than preserve health. So when we encounter these patients later on in life, they often have much more subclinical atherosclerosis or advanced disease, and we have to think about pharmacotherapy. This includes LDL lowering, blood pressure lowering. You have comorbidities like diabetes, then we think about novel glucose-lowering therapies like GLP-1 agonists and SGLT2 inhibitors. And in secondary prevention patients, we think about antiplatelet therapy, certainly with aspirin long-term, and in some people over a year or so with dual antiplatelet therapy. In general, primary prevention with aspirin is not advocated. Now, let's take a look at LDL cholesterol a bit more clearly. We reduce the risk of atherosclerosis and atherosclerotic events like MI, stroke, need for revascularization, cardiovascular deaths. And the relationship in relative terms is proportional to the absolute lowering of LDL cholesterol. So what does that mean? There is no such thing as a normal LDL. There is no such thing as an LDL that is too low in terms of benefit. But the number of events you prevent depends upon your absolute starting risk. This is the cholesterol treatment trial's third meta-analysis in 2012. And what it shows you in the vertical axis are the number of vascular events avoided, and the number of vascular deaths avoided. And you can see that over 5 years, an LDL lowering with any medication, in this case it was statins, reduces LDL by about 2.5 millimoles versus 1 millimoles, would actually prevent 6 extra events. So lower is clearly better, but this is against the background of an annual risk of less than 1%. So lower is clearly better, but if I applied this to absolutely everybody over 5 years, and the risk is very low, what I'm going to do is have some gains, but they're going to be more modest because actually there wasn't much risk to start with. Over 5 years, those people that have very high risk, so their 5-year risk is 30%, so annual risk is more than 6% per year. Instead of preventing 6 events with a 1 millimole reduction, I'm going to now prevent 61 events. However, because risk is so high, do we really want to leave it at that? And in these individuals, in particular, bigger absolute reductions will prevent many more events. So for every 1,000 people, instead of 61 events being prevented, I'm going to prevent 142 events. So that's really important in terms of policy and standpoint, because you don't want to undertreat low-risk individuals, undertreat high-risk individuals. But in low-risk individuals, you don't necessarily want to overtreat either. So this is why guidelines such as the European Society of Cardiology have a risk-based approach. We don't separate primary and secondary. So by definition, everybody with ASCVD, and these are the clinical manifestations, goes into the very high-risk category. But you could have a high-risk condition, such as diabetes with end organ damage, or, for example, diabetes with 3 additional risk factors to push your event rate very high, or severe kidney disease, for example, or a 10-year risk of dying of more than 10%, or FH, primary prevention, with an additional risk factor. These are the highest risk groups, and we want to manage all of them in the same way because risk is risk. And you'll see in this particular group, we're not doing it on the basis of LDL cholesterol, but we are going to use LDL lowering to reduce risk, and I'll touch on that in a second. So in all of the other categories, the event rate is predicted to be a little bit lower. So for high-risk people, these could be people with individual, isolated, single risk factors. And you can see that a high LDL or a high blood pressure, for example, can put you into that category. You can have FH on its own, so genetically high cholesterol levels from birth, but without any additional things that enrich it. And now, for example, the duration of diabetes is less than 20 years, but more than 10. Your renal function is not so impaired, EGFR 30 to 59. Your 10-year risk of dying is between 5 and 10%. And moderate risk, again, the risk comes down, and low risk, again, the risk comes down. All of these are primary prevention patients, no secondary prevention patients in these 3 groups. Now, the one variable that we don't think about is time and duration of exposure. Remember, in clinical trials of lipid lowering, and that's 1 millimole or 38 mg per deciliter, these are over 5 years. There is no such thing as a perfect or normal LDL. The more you lower LDL, the more you'll reduce risk. It's a straight line. But these are over 5 years. We have observational studies now, which are over 12 years duration, showing exactly the same thing. And we have genetic or Mendelian randomization. So your genes are randomly allocated at birth, at conception, and you can run higher or lower cholesterol levels based on those genes. And you can see that over 52 years, the same difference will give you a bigger treatment effect. The one way of thinking about this is I start basically and have a small reduction in LDL, but I start really early in life, let's say by the age of 20 or 25. And if I maintain that for 25 or 50 years, I will have the same benefit as starting a statin late in life, age 60. And over the 5 years after starting the statin, I'm going to get the same relative benefit, 20%. But I could be somebody who's neglected things and I interact with the healthcare system age 40. But because I've missed the previous years, I now need a bigger investment. I now need to get a larger reduction in LDL, maybe now in the 20 mg per deciliter or 0.7 millimole range, and now I'm going to get the same benefit over 12 years, but I have to maintain it 12 years to get the same benefit as a bigger reduction over a shorter period of time. So the European guidelines recommend these risk-based targets, and the higher the level of risk, the lower the target that we're aiming for. Between 2016 and 2019, 3 of the categories, moderate risk, high risk, and very high risk, the goals were lowered by about 0.5 millimole. Now, what they talk about is matching risk to LDL, but the question is, how do we get there? So if you basically have very high-risk individuals, you're going to need to get to lower LDL cholesterol goals, but statins alone may not work. So we need to think about combination therapy with things like ezetimibe and also PCSK9 inhibitors potentially being added. So one of the key things that we basically looked at in the Da Vinci registry is we asked the question, when you manage those 4 groups, how are you managing those patients? And the answer is 84% of prescribing in Europe is statin-based monotherapy. We don't use much in the way of combination therapy, whether that's with ezetimibe or with PCSK9 inhibitors. And the effect of that is, with a monotherapy approach, only 1 in 2 patients will get to the old, easier to achieve ESC, EAS goals, but with the new, harder to achieve goals, only 1 in 3 will get there. So we've got to move away from statin-based monotherapy and start thinking about combination therapies for those at highest risk. So excess risk, if the goal is 1.4 or 55 mg per deciliter, I need to think about combination therapy early. Why do we get poor implementation? One of the problems is ASCVD risk or risk is poorly understood because our patients are largely asymptomatic. We see some changes in numbers, in lipids, in blood pressure, and we tend to just wait and watch. We also don't understand mathematically the benefits, and we can't explain them properly to our patients, and our patients understand this even less. There may be issues as well regarding availability of therapies, costs, unsure about who to use them in. But let's get away from the fact that there is no such thing as too low an LDL, and lower is better. If you basically look at the trial data, and we've seen this, you can achieve LDL levels below 50 or below 40 mg per, 1 millimole, and your risk is lower for cardiovascular disease. So we don't want to, as I said, overtreat low risk, but we don't want to undertreat high risk either. And there is no safety signal either with very low levels of LDL cholesterol, and risk goes down. But think about these trials. The average age is 58 to 60. We've missed 60 years of atherosclerosis buildup. So when we talk about residual risk, some of that is because we've actually just started treatments and interventions so late. Now, we've talked about combination therapy, and we've simplified this now. And this was a recent opinion piece where we said that for very high-risk patients, we should start straight away with combination therapy with statins and ezetimibe, because this will increase the likelihood that patients get to goal. Probably about half will get to goal simply with this approach. Now, if you don't get the 50% reduction that you expect, or the LDL is above 1.4 or 55 mg per deciliter, that's the time to add in a PCSK9 directed therapy or a third oral drug like bempedoic acid. Extremely high-risk patients are patients who have recurrent events, progression of disease, for example, despite cholesterol lowering. And in these people, you should start early with triple therapy, statin, ezetimibe, and a PCSK9 directed therapy. So let's look at how these drugs work and why synergy and combination therapy is so important. This is the liver, and this is a reminder that when you give people a statin, you block the production of an enzyme, HMG-CoA reductase. So cholesterol levels fall in the liver. So what the liver does is it responds by making more LDL receptors. These LDL receptors then bind circulating LDL particles. These are internalized, the LDL is removed, and the receptor is recycled back to the cell surface. However, there is a second protein called PCSK9 that's produced. And what it does is it breaks down these LDL receptors. So even though when you give statins, you make more LDL receptors, some of these are dying and they don't live as long as they could because of the presence of this second protein. So we have endogenous levels in blood, but when you diet, when you take a statin, add ezetimibe or a fibrate, your liver makes more of this and levels go up. So it's obvious that if we could actually lower PCSK9 or stop its binding to the LDL receptor, these receptors would live longer, function better, and therefore now remove more LDL particles. Because this protein is so destructive, the way that we can do this now are with monoclonal antibodies. So we work downstream, we bind the protein, so there is less free PCSK9 to bind to the LDL receptor, so you make the LDL receptors function better. But the problem with this is the approach is it's a bit like stopping the river. If you go to the sea, you need a lot of concrete and a big dam. If you go to the source of the liver, because 80% of PCSK9 in blood comes from the liver, if you go right up to the source of the river, you only need a small amount of concrete to stop the flow of the river. And that's what these approaches, these RNA-based therapies, so-called gene silencing, how they work. They don't actually silence the gene, they silence its ability to talk and make the message because they target messenger RNA and they create the breakdown of messenger RNA, which in turn shuts down the protein PCSK9. So if you like, what we're doing is instead of collecting PCSK9 in a bucket, we are stopping the tap from leaking, which is more effective. We can see that here. If I use a monoclonal antibody at a low dose, I bind all the PCSK9, so basically free PCSK9 levels fall. But the bucket is small, the liver is leaking, so cholesterol levels come down, but they go back up again quickly. If I have a bigger bucket, I collect more PCSK9, but if I want an every 2-week injection, well, this dose isn't going to be enough because the bucket will overflow, LDL levels come down but bounce back up very quickly. So with a big bucket, I can actually have time to wait for 2 weeks before I need to replace the bucket again, and that gives me a more steady profile. On the other hand, there are two approaches we've got. The first is now available in Europe and in many other parts in the Middle East and elsewhere. And this is using something called small interference RNA. So this basically was a Nobel Prize winning technology. We have in mammalian cells a natural process called the RNA-induced silencing complex that sits in the cytoplasm, and it binds naturally occurring sequences of double-stranded RNA, and it breaks down specific messenger RNA that the body doesn't want in order to switch off certain proteins. So if we piggyback onto this and give an artificial drug targeting PCSK9, for example, and we inject that, it can be taken up by the RISC complex, the two strands separate, and the antisense strand, which matches the messenger RNA for PCSK9, will basically recognize it, and then this RISC complex, which has an enzyme, once this binding occurs, it will break that down. So if we put a drug in and it sits in the RISC complex, it can just sit there for a long time, detected from breakdown by a unique process. It doesn't work through cytochrome P450. It basically can break down multiple messenger RNA transcripts. Now, there's an alternative approach which has been tested for LPA lowering, but for antisense. It doesn't work in the cytoplasm, it works in the nucleus. And that basically is a single strand of antisense or RNA, binds to a matching sequence, and then again leads to some form of catalytic breakdown. The big difference is this has to be injected every month. This could be injected every 6 months. To get this into the liver, the approach that we have is that we can add a sugar residue called GalNAc, because the liver uniquely, and this was discovered at the University of Leiden, expresses acyl-glycoprotein receptors. And their function is to recognize aging senescent cells. And what that basically means is that if we inject any RNA-based therapy and we put this on, it goes into the liver and nowhere else. This basically is an advantage because what it means is that we can reduce the dose of the drug, reducing the likelihood of adverse events. So you can now provide a small amount of drug, highly targeted, get it into the liver within 4 hours. So we tested that in the Orion 9, 10, and 11 trials with dosing of a drug called inclisiran on day 1, day 90, and 6 monthly thereafter, over 180 days. Now, what this basically allowed was we want to look at the peak effect, but more importantly, what is more important is the area under the curve and if you like, the average reduction that is achievable with 6 monthly dosing in this window of 15 months. And what we're able to show is that highly selective, precise approach with inclisiran, siRNA-based therapy, can switch that leaking tap off. It can shut down PCSK9 levels in blood by 80% because what it's doing is it's going to the source of 80% in the liver. And this translates into very stable peak and trough. So a twice-yearly injection can bring down LDL by about 50%. We know that familial hypercholesterolemia, which is a condition that occurs in 1 in 311, and it does occur in Sri Lanka. I have Sri Lankan patients with LDL receptor mutations. This is under-recognized, and we hope that Sri Lanka will join the FH Studies collaboration, the global registry that I lead. So here was our data showing that the average age of diagnosis of FH, a condition prevalent from birth, is in the mid-40s. Means you've missed 45 years of cholesterol exposure. That's like smoking in pack years. And the later your diagnosis, the more prevalent hypertension, diabetes, smoking, and other risk factors will be. With statin-based monotherapy, few patients actually achieve goals less than 3%. You're going to need combination therapy. And in particular, PCSK9 directed therapies. So, in an FH population, this was Orion 9, the previous studies were ASCVD in 10, in 11, it was ASCVD and primary prevention. In Orion 9, what we can show you here is that in FH patients, the majority of the people have an LDL receptor mutation. If I have a patient like that, they have one faulty gene, one good gene. With the good gene, by giving them statins, I can express more LDL receptors. So even though the other LDL receptor gene is faulty. However, I'm working on half my capacity, so LDL levels remain high. If I make those LDL receptors live longer by adding in a PCSK9 lowering therapy, I can achieve big reductions in LDL and almost normalize LDL cholesterol levels. So for FH patients, we can basically use these combination therapies. The biggest impact of these RNA-based therapies is going to be on overcoming non-adherence. Basically, there's no magic about the percentage reduction your patient will achieve. It depends upon what we, the doctor, do, what you prescribe, and what the patient does. Do they follow that? Are they adherent to medication or not? So the best gains are when the doctor and the patient work together and do the right thing. If the doctor does the right thing but the patient doesn't, high intensity, non-adherent, you're here. 4% reduction. If the patient is willing but the doctor isn't, low intensity prescribing, fully adherent patient, you get a bit more reduction. So we have to work together. And this relationship between adherence and intensity of prescribing tracks exactly with risk. So what are we looking at? Well, risk, in turn, that same relationship is related to LDL, which is related very simply to what you prescribe and what the patient does. So if, for example, because LDL lowering is LDL lowering, there's nothing magical about it. If in the future, with things like injectable therapies that can be given twice a year, or vaccines once a decade, or gene editing once a lifetime. If we achieve reductions in LDL consistently, and we can overcome some of the issues related to taking 365 pills a year or 26 MAB injections a year, what we will succeed in doing is overcoming the issues of adherence. That basically means that long term, we will be able to sustain better area under the curve, better annualized reductions in LDL. So over 5 years, although the gains in this may seem to be modest over current cheaper other therapies, over 50 years, this is going to translate into a huge reduction in risk of cardiovascular events simply by overcoming adherence and improving the area under the curve. We know that decision support systems have a role to play. Patients may not be able to think, or doctors may not be able to calculate benefit necessarily. There is a secondary prevention risk calculator that the ESC, EAS now recommend, and which we have validated in routine electronic records. Let me show you 13 different patients. And like your primary prevention risk calculators, you can put in lipids, age, various demographics, and you can calculate absolute risk. These first 4 patients have a 10-year risk of 20%. The next 4, there's a 10-year risk of 40%, so even higher. And in the next 5 patients, we've kept lipid levels constant, non-HDL, but we've changed other things, and you see that the 5 patients have very variable 10-year risk. All of these have ASCVD. Now, let's say you have a restriction on your budget, and you're choosing rivaroxaban. So in the first 4 patients, rivaroxaban, because it gives you a 1/4 lowering of relative risk based on COMPASS, it's going to give you an absolute risk reduction of 4.8%. But let's say, for example, you can't afford that and you want a bigger benefit. Well, then you choose the next 4 patients where their global risk, 10-year risk, is 40%. And so the absolute benefit is 9.6%. You choose these 4 patients over these. However, unless you can calculate these in your head, you're going to need a tool like this because they all have ASCVD, and these 5 patients have very different 10-year risks, and their absolute benefits are going to be very different. Now, if you do the same thing with a PCSK9 inhibitor or any LDL lowering therapy, these 13 patients have very different absolute benefits from this add-on. And the reason is that your benefit doesn't just depend upon your baseline risk, but it depends also upon your starting level of atherogenic lipids, because the absolute lowering of non-HDL and LDL will drive the relative risk reduction, which you then have to apply to this baseline risk to be able to calculate these benefits. And nobody can do that in their head. These are now available as apps and as tools. Now, we need other things as well. There are oral therapies and new therapies, and this is a drug called bempedoic acid. So statin intolerance is something that we see, particularly at higher doses, particularly in people of certain ethnic groups, in females, older patients, comorbidities. Statins work by targeting HMG-CoA reductase. But 2 steps up from that, there is an enzyme called ATP citrate lyase. That can now be targeted by a drug called bempedoic acid. Importantly, this is a prodrug, and the enzyme to activate it is only found in the liver. So once activated, it can't leave the hepatocyte. And importantly, this enzyme is not found in skeletal muscle. It's particularly good for people with statin intolerance. However, remember, because it's in the same pathway as statins and ultimately works by increasing expression of the LDL receptor, the percentage reduction in LDL that you will gain will depend upon the amount of background statin you have. So this was the largest study which I led, and this was Clear Harmony. And on a background of very high-intensity statins, you basically reduce the LDL cholesterol by about another 18% in relative terms. But as benefit relates to absolute lowering, this is going to be great for those people who, despite statins and ezetimibe, still have a very high LDL, where now an 18% reduction in LDL will have a bigger absolute lowering of LDL and therefore a bigger benefit. In a statin naive or low-dose statin background patient, you can achieve 25 to 28% lowering because of the mechanism I've described. And there are also now single-dose combination pills with statin, with bempedoic acid and ezetimibe as a single pill, whereby in statin-intolerant patients in particular, you can achieve 38% lowering of LDL cholesterol. So in summary, start with assessing risk, treat early, titrate LDL to level of risk. You will have to use more combination therapy for your very high-risk patients. And now it's never been this good. We've got so many options. There are 3 oral therapies available, statins, ezetimibe, bempedoic acid. We have 2 monoclonal antibodies available with an injectable therapy every 2 weeks. And then we have the first siRNA-based therapy available with 2 injections a year. I hope this has been informative, and one day I look forward to seeing you soon in person, and I invite you to come and join us at the EAS 2022 in Milan, which is at the end of May. Thank you for listening.
Thank you, Professor Rai, for an excellent presentation on prevention and lipid-lowering therapy in the current concepts. And we have a few more minutes left. Any questions from the audience? Yeah, Mike, please. Hello.
Hi. Hello.
Hello.
Hi, can I ask a question?
Yeah, one question.
Hi, Professor Kaushik. Thank you for that excellent presentation. I have a question. You know, there are people, especially mid-30s, late 20s, and they are very fit people. They are fitness freak. And there is a group of people, they are called clean mass gainers. They are very fit people, metabolically normal, but they have very high level of LDL. There is a group of people. And so even LDL goes up to even 190. Are you going to treat these people with statins?
Yeah. So I think the guidelines globally now tell you to treat anybody with an LDL above 190 are basically you'll try a brief period of diet and lifestyle. The reason is that it's about cumulative exposure. So over a very short period of time, probably not much is going to happen. But if you follow these people up with an LDL above 190, essentially over about 20 years, you get 18% reduction in all-cause mortality. You get about 28% reduction in coronary artery disease death. So one of the problems is that we look at these very short, narrow windows. What you will see next year, and we'll publish this, is looking at lifetime trajectories rather than short-term trajectories. The idea of that would be to incorporate more genetic information, not just on measurable variables at a certain point in time, and to try and make small course corrections. If somebody can bring their LDL down from 190 to, let's say, 160 with diet and lifestyle, fine. But if they can't, they should probably have a discussion about the benefits of long-term LDL lowering with the statin.
Thank you.
Any questions?
There's one question. Initially, there was some concern about diabetes on long-term statin therapies. It still prevails. So, have you got any new studies on that?
So what we think about the diabetes risk is that for every 1,000 individuals that you treat with statins, there will be one individual where, let's say, the HbA1c has gone from 6.47 to 6.55. So by definition, even that small 0.1% difference in HbA1c, you've now labeled that person as having diabetes. But that does not mean that cardiovascular risk goes up. And in fact, these people that are more likely to develop diabetes are going to do so probably anyway, naturally, but will do so a month, 2 months, 3 months earlier. But the benefit in terms of a 1 millimole LDL lowering, in terms of reducing cardiovascular events, you prevent about 5 to 7 cardiovascular events for every 1 case of new onset diabetes. And in fact, even these people where glucose levels go up, because the 10-year risk is so high, you actually get bigger benefits in those individuals. Because often these people have high triglycerides, higher BMI, lower HDL cholesterol, so the absolute risk is much, much higher. So I think we've got to basically, separate a glucose change and therefore you defining. So it's like saying if blood pressure went up by 2 millimeters of mercury and my cutoff for defining hypertension is a certain level, all of a sudden 2 millimeter mercury difference, I'm going to say I have more hypertension. Of course you do. But if something else reduces your cardiovascular risk quite significantly, then you've got to look at the benefits and the harm together.
I have a question. Is there any benefit of using multiple therapies, the multiple drugs to achieve your target? For example, what I'm asking, if a patient with MI, you need to get the LDL level lower than 55. And in this patient, if you start statin, say atorvastatin 40 milligram, you get it down to somewhere around 70s. What is the best way of reducing it to 55? You are adding another more statin, say 60 or 80, or on top of 40 of statin, you are adding ezetimibe. Is there any?
That's a very good question. So essentially, when you double the dose of statin, when you go from 20 to 40 of atorvastatin, when you go from 40 to 80 of atorvastatin, you only get 6% further lowering of LDL cholesterol. So we need to become much more like our hypertension colleagues, where you get synergy. Instead of doubling the dose of a statin from 40 to 80 milligrams of atorvastatin, ezetimibe 10 milligrams will give you 20-25% lowering of LDL. When other therapies are also available, bempedoic acid, inclisiran, MABs, you're going to get either an additional 25% lowering or you're going to get 50% lowering of LDL. If you use statins and ezetimibe for your ACS patients, which I think is what we should be doing, about 45 to 50% of patients with 40 of atorvastatin and 20 of ezetimibe will get to goal. Then what you can do is think about adding in more expensive treatments for those remainders. But don't add, there's no benefit.
Yeah, in the absence of questions, I take this opportunity to thank Professor Kaushik Rai, and I would like to invite you to our session the next year. Hope the COVID pandemic subsides, and I hope you have a nice evening and another lecture. I hope you have another lecture at Royal College in a few minutes' time. Thank you very much, Professor Rai, for your kind contribution to our work.
My pleasure. Thank you very much. Have a good day. Bye-bye.